Hi, I'm going to be talking today about schizophrenia, which is a whole spectrum of disorders. Schizophrenia is one of the most severe and chronic of the mental illnesses. It affects thought, emotion, behavior. People lose touch with reality. Persons have difficulty in thinking, speaking, disorganized cognition, and often paranoia accompanies schizophrenia. I'm looking to my left, right, probably your left, because I'm looking at another computer with my notes on it. And all of this is on Blackboard for you to look at and to review if, once you hear me, there's still some confusion about it. For the most part, schizophrenia can be frightening. It has positive and negative symptoms, which I'll talk about in a minute. People have a faulty perception of the world. They don't see it the way you and I do. People can withdraw from reality and often do. People can be involved in fantasy and or delusion, where they have false fixed beliefs that create a whole kind of worldview for them. And certainly there's mental fragmentation with schizophrenia. There's a slide on Blackboard in that whole slide on schizophrenia where you'll see some brain scans done with a positron emission tomography scan. And Boyd talks about that too in the chapter on schizophrenia. But if you look at that in the top of that image, there's an active frontal cortex and lobe seen in the scan. And to the right of that, you can see where there's less activity in that frontal lobe. The same with the two bottom images. The normal is on the left, and on the right is a person's scan who is afflicted with schizophrenia. Now, it's important to make a distinction here because people can be psychotic without having the illness of schizophrenia. Psychosis certainly is an acute syndrome, and you and I have talked about that in terms of bipolar 1, and also with depression, people can become psychotic. I would say too, even with panic following some horrendous trauma, you would see some psychosis. So with psychosis also comes a group of symptoms, and psychosis also, by definition, is a loss of touch with reality. So again, looking at psychosis per se, just taken on its own, it's not a disease or a disorder, but certainly can show up as hallucinations and or delusions. With schizophrenia, the most frequent cause, or let me back up, with psychosis, the most frequent cause among other types of mental illness, schizophrenia, absolutely, major depressive disorder, bipolar 1, and maybe bipolar 2, a person's use of substance abuse, cocaine, amphetamines, PCP, marijuana, hallucinogens, health problems. People can have psychosis with brain injury and a more organic illness like systemic lupus. And intense stress may also cause psychosis. Psychobiologically, underneath a psychosis is the thought is that it's excess dopamine. And the thought of excess dopamine is also seen as a primary cause of schizophrenia and resultant psychosis. Antipsychotics, then, the medication, treat psychosis by decreasing the amount of dopamine in the brain, the available dopamine to the brain, and the dopamine in the brain. So hopefully that makes sense to you, that it does involve a neurotransmitter, and it's the excessive amount of dopamine. Here's methamphetamine excess dopamine as a slide, and you can see all the activity going on there with the use of methamphetamine. Stimulates, the release of excess dopamine in this slide. Epidemiology in terms of schizophrenia, the world prevalence is only 1%, and in the US, it's 1.2%. There's really no difference in gender in terms of how it affects persons, but you can see on the slide under epidemiology that the male person can exhibit symptoms of schizophrenia anywhere from 18 to 25 years old. So the tragedy here is that a lot of persons who go to college may experience what we call a psychotic break and or resultant schizophrenia. For women, 25 to 35, although in my experience, I've seen women also experience symptoms of psychosis and eventually the illness of schizophrenia. The longer the psychosis remains untreated, the more severe the disorder becomes. So that's a piece now in terms of how we really don't want people to stay psychotic for too long, because just like any other organ illness, the thought is that the longer a person remains in that psychotic state, the more residual effects may be on the brain. So there's a lot of thought being given to that today. And when I was working with people who had some psychosis, I worked really hard to encourage them to take medications, that this wasn't helping them overall. And certainly I was concerned about their brain. And of course, that would take me getting to know that person and being able to have that kind of conversation. Epidemiologically, we think there absolutely is a genetic connection, family connection, and certainly look at an increased incidence of schizophrenia if a parent or sibling are affected. You might even see the illness skip a generation and show up in another generation. In other words, the parent and the children don't experience schizophrenia, but maybe their offspring experience schizophrenia. Comorbidity, substance abuse, nicotine dependence is very high. Anxiety, depression, suicide, physical health or illness, cardiac disease, lung disease, GI disease, obesity, metabolic syndrome. So for people who have schizophrenia, they often don't attend to their other physical health, depending on their symptoms. And so they might experience a lot of different symptoms that go along with other difficult organicity. Nicotine dependence is very high in persons with schizophrenia, and also the use of alcohol. Nicotine, it's always been hard to encourage my clients to stop smoking, because they'll be quick to say, Jeannie, this is the only real pleasure I have in life right now. So many times they can be resistant to stopping their smoking. And I certainly understand that. And I tell them that, yeah, I can imagine. Again, neurobiologically, dopamine, and then there's thought to other transmitters in the brain may be included. Brain structure and function abnormalities, hereditary. There's some talk about prenatal stressors, psychological stressors, environmental stressors. Probably those more in terms of that kind of kindling thing where someone might have the illness of schizophrenia and some kindling effect takes place and all of a sudden they're showing their symptoms. And I think, remember in that first class when we looked at um, looking at the brain and illnesses, and the speaker said that really when we see the symptoms, the illness has been there for quite a while. I'm going to just stop for a minute and make sure that everything's working. Thanks. So I'm going to talk about symptoms of schizophrenia. Now, it's a little bit different in terms of what we call symptoms. So there are positive symptoms of schizophrenia and there are negative symptoms of schizophrenia. And for me, it was always like, well, wait a minute, how do I remember positive or negative? So positive symptoms are activities or behaviors that are added to that we don't normally see in a person. For example, alterations in thinking, delusions, which are false, fixed beliefs, concrete thinking. It's an inability to think conceptually or to do abstract thinking. And I can give you an example of that later, but very concrete. I guess, we've talked about this before. That person comes to the hospital, and I know you did that in the sim lab too. And what brings you in today? A concrete kind of thinking response would be, I came by cab or I came by ambulance. When in fact, what you're asking is, what is it that's going on that brings you to the hospital today? Alteration in speech, and there are different types of alteration in speech that occur. Alteration in perceptions are also a positive effect. In other words, you don't normally see these kinds of symptoms from a person. They're added to them. Depersonalization is one of the symptoms, positive symptoms, where that person feels very disconnected from themselves. Derealization, feeling of disconnectedness from one's reality. In other words, that person really isn't feeling themselves in the moment, and or things can seem really not real to them, and experiencing it in a not real way. Hallucinations are a big one. So this might be the more familiar. In other words, we all don't walk around with hallucinations. It's a positive symptom of schizophrenia in that it's added to. So auditory is one of the most common. And a lot of times they can be command, like, I think there was a question on one of the tests, like the woman hearing voices that she needed to smother her baby. So those are the kind of command auditory hallucinations. And then persecutory, that voice telling them they're no good, they should jump, they should kill themselves. So we really try to flush those out. Like, what are the voices telling you? So command, persecutory. Visual hallucinations. Oh, let me go back to auditory. So auditory will be outside of them, and you'll see them sort of tip their head one way or the other, trying to listen. It's not like that internal voice that you and I might have, like, oh my God, I can't believe you did that, or gee whiz, you're no good, or blah, blah, blah. It's not that kind of voice. It's really a distinct voice from the outside. Visual. Now, people will see things and see things that aren't there. You and I will be like, gee, no, I don't see that person outside your window. A lot of times we have to be careful that it's not organic, because visual may be an organic syndrome going on. So, for example, and I know a lot of you are CNAs, work in long-term care places, and people might start saying they see things. A lot of times, it's their meds, or they've got a fever or UTI or whatever. So there's some organicity going on in terms of them saying they're seeing things. that aren't there. So you and I would be clear on, geez, I better do some screening or diagnosing here to figure out what's going on. We wouldn't automatically say, oh, they're 85 and they just became ill with schizophrenia. I mean, we wouldn't do that. Tactile, touch, hallucinations, gustatory, taste, olfactory, nose. People can describe smelling something that obviously isn't happening. And again, you really have to do some differential diagnosing with these kinds of hallucinations. So a lot of times it's based in organicity. You think about people with stroke, people with traumatic brain injury can often have alterations in perception and hallucinations. Alterations in behavior. Now, these would be behaviors that we notice. One of them is called catatonia. It's a pronounced increase or decrease in the rate and amount of movement. And it's not medication induced. So that person may be fixed in a certain posture. We call it waxy flexibility. And you might wonder what's going on. Why aren't they moving, or why are they keeping still like that? And a lot of times we call it catatonia. Motor retardation. Now it's funny, some of the faculty I've talked to, they think I'm talking about this, the way we've called cognition, development of cognition in the past. And really motor retardation meaning slow. It's a word that describes slow. So it's pronounced slowing of movement. And again, I talked about that with depression, and certainly in schizophrenia, you would notice that person being very slow in movement. And as much as you'd like them to, come on, let's go, they're moving very slowly. And you're not able to really get them to move much faster. So you have to be patient. Alteration of thought. Now, there's some real important definitions here. So in other words, thought, cognition, the way that person thinks and the way they express themselves in thinking. So religiosity is one of the alterations in thought. Now, this would be a person who's absolutely excessively preoccupied with religious themes. And I know you've met some people that have been in the hospital that would be very religious. And ordinarily they might be religious, but this takes a real excessive tone to it. Magical thinking. This is when a person thinks that their thoughts or actions can affect others, and not just how our behavior does have an effect on people we're with or we care about or family or whatever, but this is like really thinking that my thoughts can really have an impact on that person down the hall. Paranoia, in terms of schizophrenia, we talk about it being an irrational fear of others, ranging from mild to profound. It can appear defensive, and that person is absolutely at risk for hurting others. Because if I think you're going to hurt me, then I'm going to take a defensive mode and possibly hurt you before you can hurt me. We know that exists in other degrees, in other degrees and other illnesses. And, let's face it, at times our thinking even can be a little paranoid, thinking that others don't like us, or, that group is talking about me. I mean, we often see that when we're working with younger persons, teenagers, adolescents, young adults, where they think people are talking about them. So, but this is a real profound paranoia. It really can actually affect how they behave with others. Thought insertion. This is real interesting. This is where my thinking my thoughts aren't my own, that they were inserted into my brain, my mind. Illogical, disorganized, bizarre thinking is another alteration of thought. And inability to maintain attention is another piece that's an alteration in thought. I'm just going to pause this for a minute. Thanks. The next set of symptoms are called alteration in speech due to cognitive impairment. So in other words, if you're listening to someone and you're hearing these alterations, and I'll describe them in a minute, it's like, wow, something isn't going on well in their cognitive domain, in their thinking, in their frontal lobe sphere. And certainly, with all the neurotransmitters, how different functions of brain can be connected as well. So clang association is one alteration in speech. Choosing words based on sounds like ding, thing, sing. And so there's like a clanging that you hear where there's a certain part of that word that's being repeated. Word salad is another alteration in speech that's due to cognitive impairment. That person will have a whole jumble of words and you're trying to follow it. And it's like, what? I don't even know what they're saying to me. I mean, this is beyond what, we think about what other people are saying and we don't quite understand them. But this is a whole like salad kind of words. And it's like, wow, I don't get this, which is always like, a good sign of someone's cognitive impairment. Again, that you can't follow it. It's like, I have no idea what they just said to me. Neologisms. This is making up words. They have meaning for that person, for the client, but they don't have meaning for others. And echolalia is a pathological repeating of another words. Like, they hear you speak, they respond by saying back what you just said. How are you today? How are you today? I mean, it's very distinct. You can't miss that one. Circumstantial, a person includes unnecessary and often kind of tedious details in their conversation. It's like, if it were somebody that we were friends with, we'd say, you know what, you need to get to the point of this, because I don't know what you're talking about. You're going all around in terms of what you're trying to tell me. Tangential goes off in tangents in a way that takes the conversation off topic. Like, I taking a plane to Texas, and Texas, the blue bells are out now, blue bonnets are out now, and they're in full force, and you really should take photographs of them. And I have a nice camera, and it was given to me by, so it just takes off in all these different tangents. That's where the word comes from. Cognitive retardation, again, the word is terrible, retardation, but what's meant here is there's a definite slowing in the pace of thinking, and that person delaying their response to you, and maybe even finishing something that they're about to tell you. So that's where your skills of listening really have to come in, where, you're like, so how did last evening go for you when you had visitors? All right. And it's like, and then you're thinking, well, did they hear me, or should I say anything? And you got to know there's just such a slowing. And if you can even imagine, how the brain is working and things aren't firing in the correct way, over firing in some ways, creating delusions and hallucinations. And then in other ways, there's a very slow connection that's going on. Poverty of speech is another alteration in speech. It's called alogia, and it's a reduction in the spontaneity or volume of speech. Excuse me. So even trying to sit and get connected to that person, a lot of times it's like, oh my God, I just had such a hard time. They didn't respond to me. I could barely hear them, and you'll think that they're more or less um, not interested in being with you, but to realize that these are some of the symptoms. Flight of ideas, moving rapidly, one thought to another, similar to when we talked about bipolar 1, where there's this excessive manic kind of behavior and people just moving from one thought to the other. Pencils, and then, I had some pretty brushes I used for watercolor, and then I love going to the ocean. The water is beautiful this time of year, although it's cold and we're supposed to have snow, and like, oh my God, again, you're trying to sit and remain focused and listen to them, and they're just going all over the place. And you'll, beginning practice of this sort, you'll think there's something wrong with you when in fact this is happening all within their brain and their systems. Thought blocking. Who came in to visit you last night? Um, um, it's very profound. Probably when you're really tired and you try to pull up a name. Like, what movie did you see last week when you went to the movies? And it's like, oh, I can't believe I can't think of the movie, and you're kind of sitting waiting for that thought to bubble up. So you'll see a lot of that kind of thought blocking, and you'll want to put words in there. And sometimes it's okay, like, oh, my sister, Jennifer, so sometimes you can help them. Other times you won't know what's going on, and you'll just be aware that something is in the way of their thinking. All right, I'm just going to take a pause for a minute, and then I'll start talking about the negative symptoms of schizophrenia. So the negative symptoms of schizophrenia. Now, if you remember what it's like for people having depression, like that low mood and negative thinking and negative things going on, you'll remember that this is what we call negative symptoms. Usually present even when psychotic symptoms are not occurring. Like in working with a lot of people who had schizophrenia, their moods would be low, and at times they would get lower, and I would say to them, boy, doesn't sound like you're doing real well now. I hear you, and you just seem more and more down. So these are some of the negative symptoms that you'll be aware of. So first of all, affect. If you remember, affect is what I can see on someone's face or how they're appearing to me. Can be flat, immobile, blank, blunted, similar to someone who's depressed. Blunted meaning reduced or minimal facial. Flat is immobile, just like, I don't even know if they heard me. Inappropriate is another one, like, laughing when really there's been nothing happening in that moment. Now, sometimes they may be hearing voices and laughing with the voices, but it's almost like, you're not feeling well and you're giggly and just kind of laughing, and it's like, wow, this doesn't really go along with how you're feeling. You're telling me you're in a lot of pain and you're laughing. So it's incongruent. That's what we say. So I think of negative symptoms as they're the taking away symptoms. You know, normally we have interest in life and we're pleasant, we feel pretty good, we're pretty stable in our mood. So the negative symptoms are things that are taken away from that person. They're not added on, like hallucination or delusion. So similar to depression, there's anhedonia. And I know that I asked you in one of the test questions about what that meant. So loss of interest in things or loss of pleasure in things one used to enjoy. You know, you love bowling with your bowling league, or you loved to ice skate, and your friends are like, come on, let's go ice skating. And you're just like, oh, I can't even imagine. And that would bring me no pleasure. So pretty much not having pleasure in what one normally would have pleasure in. Negative symptoms can also be loss of emotions. It's really hard sometimes to understand what that person is feeling, um, you know, to help them describe what it feels like. And as you work with people with schizophrenia, you'll get to that. Like, how is your friend in the boarding home? Do you still go out for walks? Do you still go downtown and get a coffee? No, I just don't really. No, I don't. So, you know, you would be clear that there's some of that anhedonia going on, and loss of emotion. Loss of concentration is big. You know, even having people in groups that are in that acute phase of schizophrenia, it's real hard for them to maintain their concentration in a group. So a lot of times they're not going to be in a CBT group or a DBT group. You might have them in some activity or out on a walk to try to get some of the endorphins going and or get their body moving. All right, I'm just going to take a pause again right here. So back to negative symptoms. Affective symptoms, person's mood is definitely essential for making that diagnosis. Depressed mood can be common and increase their suffering. Mood may be depressed, elated, unstable, erratic, or hostile. So, you know, pretty much prepared for a wide spectrum of moods. And people can't always name them, you know, like you and I sometimes can't name what we're really feeling in terms of our mood. A change in mood may herald impending relapse. The schizophrenia is chronic, and yet there are acute episodes, just like any other kind of illness, where there's a chronicity to the illness, but there's also periods of acute. And, excuse me, a lot of times I would work with people who had schizophrenia, and at times, like I mentioned before, I'd be aware that they seem more depressed. So I would ask to see them more often. If you could come in more often, that would be good. And a lot of times we would change their meds, most likely increase their antidepressants. Substance abuse risk, absolutely. You can imagine living with this difficult illness and wanting to drink, or mostly it's alcohol use that people get involved in, and it certainly complicates things. But you can imagine not wanting to have this, not wanting to feel this way, just wanting to sort of be blank. So there is an increase in substance abuse. And really, it kind of goes without saying that a lot of people will be abusing substance and may also be addicted to substance. I mentioned nicotine before. Hospitals used to let clients sit in a smoking room and smoke. And then, of course, that's no longer allowed. And now people can't smoke near a hospital. They need to go far away. So when I was at the state hospital, it was difficult because some people, they're not safe enough to let them go off by themselves. So we would have to do walks. Staff would accompany them and get far enough away from the hospital. Again, I wasn't real determined to get my clients to stop smoking because it really became something that they would look forward to. And as you can hear, there's not a lot of joy in having schizophrenia. There's an increase in suicide risk. People have said to me, Jeannie, I just can't do this anymore. I don't want to do this. And of course, it was always up to us to make sure they were safe and have to hospitalize them. Also, people would get real paranoid and or hear voices that they needed to kill themselves, jump off the cliff. Different voices telling them what to do. Those are tough. They really are, because it's so real to them, they can respond to that. So to continue with the behavioral physical symptoms that are pretty peculiar to schizophrenia, it's what I kind of call in the slide. Motor agitation, excited behavior, running, pacing rapidly. You can see that sometimes too with someone who has schizophrenia. Waxy flexibility, I mentioned that when I talked about catatonia. It's extended maintenance of posture, and it's sort of like that person is posturing, we notice things like that. So we call that waxy flexibility. Echopraxia, a person might mimic the movements of another and sort of like, wow, that guy's doing what that guy's doing. And you might notice that as well. Behavioral, physical negativism, it's just kind of what it says. Resistance may not be intentional, might do the opposite of what has been told, fails to do what's requested. And you might say, wow, they're really stubborn, but it really becomes part of the illness that that person is experiencing. Impaired impulse control, that person may have a reduced ability to control their own impulses. Can be a mild piece, or it can be pretty problematic. I think I mentioned to you, I worked with some people in hospital who could become pretty aggressive and were maybe responding to voices or misinterpreting data that was coming that way. Gesturing, posturing, assuming unusual or illogical expression. Often, I've got here on the side, often grimacing, and you're like, are you okay? And, that person can even wonder, why are you asking me? We all saw Paula in Sim, and she was pretty sick when we interviewed her. I don't know that there was a safety concern, but she definitely exhibited a lot of the symptoms of schizophrenia. Yeah, and oftentimes you wonder if she had heard you or not. Boundary impairment. This can be a big one that, people have, they don't have an ability to know where they end and you begin, so they can absolutely be right up in your face. And of course, you want to say, gee, I'm really uncomfortable. I'm going to back up a little, and kind of describe your discomfort with them coming into your space. Um, so, not having an awareness of how they fit in terms of space and being near other people. So, nursing process treating persons with schizophrenia, of course, you do an assessment. So, what you're looking at again is positive symptoms, things that people don't ordinarily exhibit, negative symptoms, which kind of go along with how we see people who are depressed. Cognitive is very big, that frontal part of their brain isn't working, and the ability to connect different parts of the brain is very slowed and or may not be present in the moment. Affective symptoms, what we see, what we observe. Medical problems you want to look at. In other words, if you don't really know someone and you suspect they have schizophrenia, you'd want to do some differential diagnosis. Like, is there something else going on? And there can be many, many um, physical illnesses that can create some of these same symptoms. You want to do a screening of their abuse or dependence on drugs, alcohol, nicotine, caffeine's big. I had a client who would always complain of not sleeping well at night. And so, I would say to her, well, what happens at night? Well, I go to bed and then I wake up and then I go downstairs and I make a pot of coffee. And she lived in a group home. And then I would drink coffee and have a cigarette. And I'd be like, boy, if I did all that, I wouldn't be able to get back to sleep. And I would try to say that in a non-critical way, hoping she would get it. And she was just like, no, I love coffee. I need to have coffee. So she and I learned to live with the fact that she didn't sleep well at night. Included in your assessment also is suicide risk of harm to others, especially if they're getting command persecutory hallucinations or being told they need to defend themselves against you. Command hallucinations, I hear voices, and that person appears frightened. I think I included that too in one of the exams. And it's like, what are the voices telling you to do? And sometimes people will be very forthcoming with what they're saying, and other times they may have some feelings that go along with that. They might feel badly about admitting to some of the commands, some of the voices, what they're telling them. A lot of times they're no good, and or they might even recognize that voice of a person who may not still be living. Delusions, what's their thinking like? Is it logical? Is it coherent? Does it make sense? Are they believing something that you're pretty sure isn't true? But, just as a warning, you got to be sure that that might be some kind of false belief, because sometimes their beliefs are true about someone's trying to hurt me, and you're thinking, oh, brother, they're having some hallucinations, hearing a voice or thinking someone's about to hurt them. And then to find out maybe they live in a boarding home and there are people there that kind of pick on them or whatever. You have to assess their risk or ability to hurt themselves. Big thing is, are they taking their meds? Because, with schizophrenia, just like a lot of the other illnesses, if a person is adhering to treatment, and especially medications, people can do really well. People who have paranoid schizophrenia, if they stay on the medications and follow treatment, can have very productive lives. The problem is a lot of times people with schizophrenia don't have that insight, like, oh wow, I'm not doing well. I'm not thinking clearly. So I really should take those medications. So we do a lot of teaching around that. Mental status exam, you would do all that, just like you do assessments on the adult floors that you've practiced in. And in terms of the SIM experience, you were, I'm sure, taking in what that person was presenting. And then the client's insight into their illness, which is not always accurate, or they don't have that insight into what's happening. Family's knowledge, friends of the clients, what they've been like. A lot of times, you get their permission to talk with their families, find out how are they doing at home recently. I know that they seem a little more depressed. What's happening for them at home? Critical assessments include depression. A lot of times that can be a tip that there's an impending relapse. If you're finding that they're drinking more or using other drugs more, all of these pieces really point to the illness becoming more acute. And again, remember, acute phase is chronic. It's always a chronic piece. Increase in suicidal risk. So it goes without saying that you would admit people who were in that acute phase of schizophrenia. So to keep them safe and keep others safe. And also you look at their functioning. Like you really have to know people. You have to understand their baseline. And you might, like, as I said before, the fellow goes out for a walk every day and all of a sudden he's not, and he doesn't want to go, not getting dressed, not coming to meals. You know that there's something isn't going well for them. So like any other illness that's chronic, there are phases, stages of the illness, both chronic and acute. So sometimes we talk about prodromal. I don't know if you've heard that word used before, but they're kind of like negative symptoms that we notice. Like I worked with some young adults who, boy, their thinking was sort of off a little, and I couldn't sort of figure out where they were in things, like in terms of their function. It wasn't magical, but just a little odd. It was off. And sure enough, that person might turn out to have more significant symptoms of schizophrenia. So we call those prodromal symptoms. And what is more exciting about that is if we can make some sense of those prodromal symptoms and begin to treat people so they don't have to get into those acute places of the illness. So acute meaning onset or exacerbation of symptoms. And for us, the goal is to keep them safe and hopefully to get them back to their place of baseline. Stabilization, again, getting them to their previous level of functioning. I mean, it may not be, how we see people optimally living, but that they get back to that kind of living that they've had in the past, where they're able to have some sense of their own life and be cared for, be safe, be able to interact. And then maintenance is another phase. And, at Medici Outpatient, like I would see people with schizophrenia that were stable. I'd see them probably 3 to 4 weeks. And they would often come in and see the psychiatric nurse to talk about their meds. You know, and that's where too, if they haven't burned their families out, because there's a lot of that for families, that, you know, you do some education with family members and support with them, and prevention interventions, teach them ways of intervening, usually earlier, like as soon as you see some kind of change, the better, so that that person doesn't get sicker. So again, nursing diagnosis post-assessment, there's a whole bunch of things. Positive symptoms might talk about disturbed sensory perception, risk for self-directed or other directed violence, impaired verbal communication. In terms of negative symptoms, social isolation, chronic low self-esteem. So there's a whole bunch of nursing diagnosis that we can give. So goals of treatment in that phase 1 acute, we're looking for safety and to stabilize people. Phase 2 stabilization, we're involved in helping that person understand their illness and the treatment, what it's for, and stabilize their medications and how to cope or control their symptoms. And then phase 3, the maintenance goal of treatment is to maintain achievement of stabilization, prevent relapse, and achieve a more independent, satisfactory quality of life. And many people who are maintained and do well in the community can talk about that. There's things they enjoy, they can have some friends, they can walk, they can walk into town, have a coffee, and can find some pleasure in life. So goals of treatment in terms of stabilization and maintenance phases. Medication is big in terms of teaching persons about administration and also taking their meds. I mean, with so many of mental illness, people say, oh, I feel better, I stopped taking my meds. And honestly, for people with schizophrenia, once they stop taking their meds, they have less ability to think about what's going on for them and like, oh yeah, I stopped my meds, maybe I need to go back on them, you know. And so a lot of times we have to help people realize that. And when I worked in outpatient in home care, we had a mental health home visit team, and it was around making sure people were taking their meds. So we would go in and set up their pill boxes for a week, and oh gee, I noticed you didn't take this pill all week, this is left over, you know, and I wonder why. You try to build relationships. You try to help them trust you as a provider. There's an art to that. And sometimes it's very slow. But over time, people can begin to trust you. And even if I had said to someone, boy, I don't think you're doing well, they would know that I was being honest with them and really trying to help them notice that. And then community-based therapeutic services, whenever I know for you that were able to do some work clinically, and how unfortunate it is that some of you were not able to experience that. I'm sure that you heard the treatment team talk about post-discharge plans and trying to get people connected to some community-based services. It's not always easy. There's less and less services available, and a lot of times our clients wouldn't be motivated to go. You know, they may not feel well, or they don't think it's helping them, or they want to go for a smoke, or, you know, a lot of different reasons where they wouldn't really follow through on that. So in the acute phase, this would be in the hospital. You would see things like the psychiatric, medical, neurological evaluation done, psychopharmacological treatment, um, coming up with medications that do help that person return to their baseline, and trying to encourage that person to take their meds and what the medications were for. You know, sometimes people would have horrible voices that they were hearing, just torturous. And we might say, Bob, Carol, this medication can help you with the voices. It can help tell them or take them away, not tell them, but take them away so you're much more comfortable. Supervision and limit setting in the milieu, especially if that person's paranoid and can become more aggressive and you're concerned about people's safety. You want to monitor food and fluid intake. They may not be eating, may not have any appetite. They're just not motivated to come and eat at community meetings or community dining room. And, just really don't think about feeding or drinking um, fluids. Um, you may have to assist them with hygiene. I think previously we talked about that fellow who was really depressed and needed you to cue them. Here's a face cloth, here's soap, here's water. And sometimes people with schizophrenia will just tell you, no, I'm not taking a shower, I'm not taking a bath. They could certainly be malodorous and not much motivation in terms of getting themselves all cleaned up. So, you'd have to apply a little pressure, like, you need to bathe today. You haven't in a couple of days and you need to, and I'll assist you and help them as much as you can. Monitor sleep, the duration, the amount. We do that for everyone that's ill with mental illness. Stabilization, again, medication administration adherence, relationship with trusted providers, community-based. Specific interventions for maintenance phase, communication techniques, counseling techniques, dealing with hallucinations, delusions, looseness of association, health teaching, health promotion. And a big one we found so important and see it as more and more important all the time is vocational rehab. People who have some purpose in their daily life, no matter if you are healthy or you have a mental illness, get a great sense of themselves by volunteering or having a small job, some way they can be productive. And so we found persons, especially with schizophrenia, who would get up, get dressed, go do their volunteer work, or go do a job that's not too complicated, would be much more motivated and participating and socializing. So, that's a really important piece. We don't always hear about it or see it in action, but just to keep that in mind too as you're practicing nursing, that how important it is for people to have some meaning in their life other than for themselves. Evaluation, in terms of the process, the person attains a level of physical, emotional, cognitive functioning that they can have some meaningful life. And again, it may not be the life you would wish for you or friends or family, but it may be a life that they're comfortable with and that has some meaning. That person stays on their meds, that they get support and encouragement for that. It used to be that we could go in and do mental health visits as part of a home health agency. Depending on funding, it changes over and over again, which is really pretty sad. Because people could do well, they wouldn't come out and socialize, but they'd know we're coming a certain day and time, and they got ready, and we would chat and then look at their meds and see how housework was going. They might need some help with that. Was their case manager involved? Were they able to get out and go to other appointments? And people can do well when they're involved socially, again, in some kind of meaningful job or volunteer position. So there's a video that I want you to look at. It's by Ellen Sachs. She's a prominent legal scholar, and the video, it's a TED Talk video. It's just so compelling. And she talks about what it's like to live with schizophrenia and what it was like for her when she was in that early acute phase of realizing, and other people realizing, that she had schizophrenia. So I'm going to end, and what I'm going to do is put this video link to Ellen Sachs' talk on Blackboard. And I'll also write to you and explain what you need to do with that. And then I think the next taping I should do is on the psychopharmacology of treating someone with schizophrenia. So I'll develop another talk on that. And then again, I'm going to try to come back to each topic and do like an hour or less of time. I always talk too much. I think I've told you that. So I'm trying to be mindful. And yeah, I'll see you soon.